looking forward. And without further ado, I think we can probably give a kickstart. And Dr. Ali, if you can please come over and.
Assalamu alaikum and good morning. I can tell you how happy I am to be here. It's for Momin, myself, and Zubair. Virtually, it's like coming back to our roots. And it was such a great pleasure also to coordinate all this with some very hardworking individuals from Pakistan. First and foremost, Dr. Mudassar. I've not known him before, but what a wonderful guy he is. Great organizational skills, Mudassar. Asif and Shahid I have known over the years. I remember we first met in Tokyo at JSCC meeting, and Shahid and I met first in Hong Kong at Prince of Wales. And I think once we met in Vietnam also, so of all the places in the world. And now for the first time we are meeting in Pakistan. So I would also like to extend my thanks to my co-presenters, the faculty. Momin is here, and Ashish and Zubair would be joining us virtually. And we are all so delighted that we brought the International Academy of Cytology tutorial to your footsteps and to your doorsteps. And I'm sure that you will find it very useful and informational as we proceed with the presentations. So it's a two-day tutorial. I know it's very hard to sit in the chair for that long. So all I can advise you is to just sit back, relax, and enjoy. I have been doing these tutorials since 2013 when I chaired the committee of the IAC, the Educational Committee. And one thing I have said in the beginning of these tutorials to the audience is that you will enjoy it more if you consider it an interactive training session. And a lot of things the presenters also learn from the audience. So talk to us, exchange ideas during the break, but even during the presentation, you can just raise hand and ask question, and we can have a good discussion. We'll try to follow a reasonable pace in presentation, but since there are a lot of subject to present, we'll try to stick to the time as much as possible. And in the beginning, I just wanted to let you know my plan for presentations. Since I'm doing the morning session, I will start with the Bethesda thyroid presentation, followed by some unknown interactive cases. Again, I'm emphasizing the word interactive because then that's the time we'll talk to each other. And then there'll be a short break. I think it's 10:15 if I'm correct. And then, or 10 to 10:15, I think. And then after that, I'll continue with my unknown cases. And after that, I would like to introduce the IAC more formally to you. So again, it's time for me to formally extend thanks on behalf of the International Academy of Cytology for everyone for hosting this wonderful event, and to each and every one of you for coming in so bright and early to attend this tutorial. So with that, I would start with my presentation, and this would be, if we can get to the first slide, please. So this is something which Mudassar also mentioned, that Bethesda system for reporting thyroid cytopathology has been around for some time. Now it's undergoing the third revision, and I'm happy to report that just last week, the print version of the book came out. The electronic version was out for more than a week, so it's very timely that I make this presentation to you. I had done a similar presentation for the Shaukat Khanum Memorial course last year, but I've done some updates and will be presenting to you some additional information. So as the title conveyed to you, now we have the third edition or 2023 edition of the book. I have no conflicts of interest, and I often say what my dear friend Dr. Magdeme used to say, that I have no interest in conflicts. So this is what the 2010 and 2017 Bethesda system looked like. There were 6 reporting categories, as you can see here. So practically 100% of the diagnoses that we used to make would belong to one of the 6 diagnostic categories. The other thing which you would notice here is that there are 2 names for 3 of the 6 reporting or diagnostic categories, and that added to a lot of confusion and was a point of a bit of a contention over the years that why are there 2 names. Although it was a consensus meeting that we have at NIH in 2007 when we created the Bethesda system, but we could not agree to a single name. So at the end, we ended up endorsing 2 names with the strong recommendation that you use one name or the other name, but don't use those 2 names interchangeably. But over the years, we saw that despite our recommendation and at sometimes please, people started to use the name interchangeably. They, for example, if they would see a cytologic or nuclear atypia, they would call it AUS. And if they would see a microfollicular proliferation, they would use the term FLUS. This is something which we strongly discourage, and I'm happy to report that in the new edition, we have gotten rid of the double names, and there would be single name for each of the 6 diagnostic categories. So as seen here, there was no change in the names of these 6 diagnostic categories, but in the 2023, we have made subtle adjustment to the names by also providing a single name. The other thing which I want to point out here is listed here that the success of the Bethesda system when we introduced and published the monograph in 2010 was that it was built on a framework of what we call probabilistic approach, meaning that the probability of finding or encountering a malignant tumor or risk of malignancy was implicit in each of these 6 diagnostic categories, which provided very useful piece of information to the treating physician, and hence it was right away endorsed by all professional endocrine and head and neck surgery organizations. And since it was a multidisciplinary approach when the Bethesda system was created, each of these 6 diagnostic categories are linked to very well-defined management algorithms. So everyone knows what the plan would be if you use one of these 6 diagnostic categories. So since the publication of the 2017 Bethesda, we thought that there were changes that have taken place in thyroid disease. The most important of which was that new data was available to us based on prospectively analyzed studies. And we saw significant change in the risk of malignancies of these 6 reporting or diagnostic categories, and we wanted to update the ROMs. Also, molecular testing, which was present in 2017, but now we notice that the menu that they offer, that number of tests and type of tests, the molecular alterations that these tests offer have expanded further, and we wanted to incorporate those expanded menus and options which are available to us through these commercially available molecular tests. American Thyroid Association is the premier organization of endocrinologists and head and neck surgeons, and since they officially endorsed the Bethesda system, they were in the process of updating their own guidelines, and we wanted to join hands with them and be in alignment with the new ATA guidelines. And that was another reason for us to consider an update. And as I mentioned, we wanted to give single names to the 6 diagnostic categories. The 5th edition of the Blue Book, the WHO book for the histologic classification of head and neck tumors came out. There was some change in the nomenclature which we wanted to incorporate in the Bethesda system. And I'm happy to report that we are in complete agreement and alignment with some of these new names. Bethesda system had always been a global international reporting system, but this time we made an extra effort to offer multinational authorship to experts from all around the globe. And hence these were the reasons that we now have the 3rd edition. And this is the title, which is the title I used when I presented, made a presentation as the moderator of an extended session in the last International Congress of Cytology in Baltimore last November. And today also I'm using the same title, that we really wanted to give a near perfect title and role in the reporting of the patients with thyroid disease when we revisited the Bethesda system. So these are some of the new things with the 2023 Bethesda, the 3rd edition. That's the new name. We have a new co-editor, Paul Wonderland from the Harvard system. Dr. Ed Sebas, who had done the previous 2 editions with me, wanted to step down. For the first time, we also invited 4 associate editors because now there's a much more elaborate, extended discussion in the book, and we wanted to have more experts on the book. Zubair Baloch, who is on the faculty for this tutorial from the US, Beatrix and Philippe from France, and Fernando Schmidt from Portugal, all very well-known expert in thyroid cytology, are on the book. Also, the authorship was increased to 65 in the 3rd edition. We have more clinicians and radiologists. We have always accepted the fact that it was a multidisciplinary approach when the Bethesda system was created, but we wanted to acknowledge their role in a better fashion in the 3rd edition. The important feedback and the important contribution of the radiologists and the clinicians. So hence you will see more inclusion from those 2 groups. We have 2 new chapters because now the molecular and ancillary testing plays a very important role. It was always there in thyroid cytology, but now we have witnessed that their role have really expanded. So we have a dedicated chapter on that. And also, for the first time, we further acknowledge that the workup of thyroid patient does not just involves FNA cytology, but there is a very important role for the clinical presentation and the imaging findings when we read the FNA slide from a thyroid patient. So you will see these 2 new chapters. As I mentioned, ROM's risk of malignancies have been revised. And also for the first time, we acknowledge that the thyroid disease in children behaves differently from thyroid disease in adults. It's much more aggressive. There are higher risk of malignancies in Bethesda categories, and hence the options of surgeries are more often available to treat these nodule and pediatric patients. There are single names for each diagnostic categories, and I'll show you in next slide how we address that. AUS, atypia of undetermined significance, has always been a thorny issue. I know that there's a level of subjectivity involved. My AUS might not be your AUS and vice versa, and hence we wanted to simplify it further. And I'm happy to report that we only have 2 subcategories of AUS, and I'll elaborate on that when the slide comes on that particular topic. Also, as I mentioned previously, now the terminology that we are using because the system is in complete alignment with the new WHO terminology. The book just came out a few days ago, so we have it in our hands now. So this is the important slide, very simple slide, but it shows you the new names. We have gotten rid of the term unsatisfactory, FLUS, and suspicious for a follicular neoplasm. Unsatisfactory has always been a very harsher term, and I can't tell you how often people, endocrinologists, have called me up, or head and neck surgeons, that please use non-diagnostic, don't call it unsatisfactory because it makes us look bad in front of the patient. And also, not everything which is non-diagnostic is unsatisfactory. For example, the cyst fluid FNAs, although we call them non-diagnostic because we don't have the cells to make the diagnosis, but it's not unsatisfactory in that sense because there's just a simple cyst, and your radiologist or you yourself or the endocrinologist will aspirate all the fluid from the cyst. So technically they did everything possible to give you the material. So hence non-diagnostic will be the only term used. Also, FLUS has always been an unfavorite term for both for me and at CBUS. We have never used that term, but in the beginning, as I said, we had to endorse it because we wanted to be completely inclusive of everyone's opinion when the Bethesda system was written up. But now we, after much discussion back and forth between the groups of people supporting one or the other, we decided it's time to junk FLUS and only use AUS. I have always used the term suspicious for a follicular neoplasm. Personally, at Johns Hopkins, I favored it over the term follicular neoplasm, but the people who support follicular neoplasm are of the opinion that whenever you put the word suspicious in a cytologic diagnosis, clinicians usually take it as suspicious for malignancy, and I think they have a strong point because sometimes The same word, if it's used in histopathology, simply would mean suspicious. Suspicious for what? Suspicious for malignancy, and hence it does create some confusion. But on the other hand, we all have the understanding that no matter how good you are in thyroid cytopathology, how experienced you are, 1/3 of the time, 32% of the time, you will not be able to discern between follicular neoplasm and adenomatoid nodule. You will overcall your adenomatoid nodules as follicular neoplasm because the tip of the needle may sample an area in a hyperplastic nodule with all microfollicles, and hence using the simple morphologic criteria, you will make the diagnosis of follicular neoplasm. So that's why we always like the term suspicious for a follicular neoplasm. But now, after having endorsed follicular neoplasm, we strongly recommend that you put an optional note after that diagnosis that 32% of these cases diagnosed as follicular neoplasm on follow-up may turn out to be hyperplastic nodule, to protect yourself, your clinician, from a patient who might be upset why a lobectomy would be done in a hyperplastic nodule. So again, to reiterate and remind you, non-diagnostic, AUS, and follicular neoplasms are the terms that would be used. The other terms are now obsolete. So this is an important slide because it beautifully shows you the transition and risk of malignancy from the first edition, the second edition, and the third edition. So the one in black in parentheses are the risk of malignancies from the first edition. The one in red are from the 2017 edition. As you can see, they kept on increasing, and the one in green are from the 2023 edition. This time, we have also given, in addition to the range, a mean value, which is written in parentheses. And I think this is a very important value because if you have to compare your institutions or your own risk of malignancy to the Bethesda, published Bethesda, I think the mean values would be of much more importance and meaningful for you to do that. And also the management algorithm has evolved a little bit, as you can see from the red, which is 2017. Now, slightly more conservative approach is practiced. For example, in AUS, sometimes depending on the type of AUS, and if the patient does not have a family history or risk factors clinically or imaging-wise, simple surveillance is often practiced. And also we have seen an emerging role of molecular testing in suspicious of malignancy and often in malignancy also, because the molecular tests now with their extended profile give you specific information on certain mutations against which you can use targeted therapies of precision medicine. So it's important that we also, in case the provision of molecular testing is available at our institution, we use it in these two categories as well. So this again is an important slide because the first time it shows you how the disease in children is different. So the one in green are the risk of malignancies in adults, and the one in red are in children. And as you can see, when you get to the follicular neoplasm to malignant, it's significantly higher, in some cases approaching 100%, and hence often a lobectomy or thyroidectomy is done in children. So it's important that in children we have that understanding that the disease will be different, with more chances of the nodules being malignant in our pediatric population. So I often show this slide to acknowledge the tremendous role of imaging, and not only in the workup of a patient with a thyroid nodule, but also at the time when you perform the actual fine needle aspiration. Again, reiterating that all thyroid FNA should be done under image guidance, because you can see the tip of the needle, which is echogenic because it's a tiny dimple which makes it bright on ultrasound. And so you know where the tip of the needle is when you obtain the sample, and it becomes more important if it's a complex cyst with solid and cystic areas, because intention is to go after the solid areas. And also, not only it assures a better sampling, an accurate sampling of the lesion. Sometimes if you, for example, in this case, turn on the colored Doppler, it shows you if there is any potential complication like a hematoma formation. You can then offer the patient conservative therapy, which is would simply be cold compresses. And in this particular case, you can actually see with the arrowhead the source of the bleeding vessel. And again, with ultrasound, your intention is not to puncture the big vessels running in close vicinity of the thyroid. So you do the clinical examination, you add the imaging findings, and then take the patient for FNA cytopathology. So two additional things which are important when you're working up these patients is the understanding that imaging also gives you more information when it comes to the thyroid nodule. It gives you, in half of the time, 50% of the time will show you more significant finding, additional significant findings like additional nodules in the thyroid or cervical and large cervical lymph nodes. So that is also important that these cases should be done under imaging guidance. And also 1 in 6 patients, you will not find the nodule which led to the patient coming to you for fine needle aspiration. So you can obviate the need for an unnecessary FNA when you have imaging available to us. So it's two very important facts to remember, reminding you the importance of ultrasound guided FNAs in these patients. So I have always considered molecular analysis as part of an FNA analysis because it is done on liquid sample, which we as cytopathologists obtain or evaluate. So once you have the morphologic finding and you have the molecular testing results available to us, then you issue a final report, which in case it's benign will simply lead to clinical follow-up in these patients, or if it turns out to be a neoplasm or a malignant tumor, then patient can either get a lobectomy or a total thyroidectomy depending on the scenario. So now I will address each and every single Bethesda categories one by one. Non-diagnostic, interestingly, the incidence is 2 to 20%, and the risk of malignancy also ranges 2 to 20%. But as you can see here, despite the wide range of its incidence from lab to lab or individual to individual, 10% is the cutoff that we mandate in Bethesda system, that not more than 10% of all your thyroid FNAs should be non-diagnostic. If it's higher than 10%, 15 or 20%, then it's too high. You have to bring it down, and rapid on-site evaluation definitely helps. A good technique helps with a skinny needle, short needle dwell time, the amount of time needle remains in the nodule, and also no suction. These are some of the tips that I could give you for obtaining a more diagnostic sample. Adequacy criteria, unfortunately, remains the same. 6 group of follicular cells, roughly each with 10 benign appearing cells. You can have all the cellularity on one slide, multiple passes, single pass, it doesn't matter. Very flexible criteria. You can have one large gigantic fragment on a single slide rather than individual 6 fragments. You can arbitrarily divide the larger fragment in your mind and count them as separate fragments. Also, with the understanding that if you do liquid-based cytology, thin prep or sure path, you will have more individual singly dispersed cell, because in liquid-based cytology, you dissociate the fragments. Again, you can count roughly 60 cells and call it adequate. If you ask me how often I count the cells, never. So it's just a rough guess, an eyeball count that you do when you call something adequate. And this adequacy criteria is very important for you to understand. This applies to hyperplastic nodule diagnosis, adenomatoid nodule. It would not apply to lymphocytic thyroiditis in cases where you have abundant colloid, or if you're calling something AUS or higher, follicular neoplasm or higher, then the count is unimportant because you have already made up your mind to use another Bethesda category. So there are several reasons of making a non-diagnostic FNA, a very bloody FNA, obscuring the cells, not enough cells, which I already mentioned, air drying artifact. But important thing is, because of a significant risk of malignancy approaching almost 20% in certain studies, these patients should never be left alone. They should be brought back for a repeat FNA. And again, the important age-old question is, what should be the interval for a repeat FNA? 3 months is something we suggested in the first edition. 12 weeks, we recommended in 2017 that it could be significantly shortened. And in 2023, once again, we strongly recommend that it could be a much shorter interval. In my practice, if someone calls me up, I usually tell them you can bring the patient back in 1 month. I think 4 weeks is a pretty good time interval to do a repeat FNA without running the risk of overcalling some of the reactive changes induced by the previous FNA. So just remember that. The question is that I repeatedly mentioned the important role of ultrasound when you do the FNA. So do I do the ultrasound myself or with the ultrasonographer and do the aspiration? The answer is no. So we always have the radiologists who would do the FNA. But since we train our own fellows, and as you know that since we now recommend everything should be done in ultrasound guidance, so our fellows get trained on ultrasound-guided FNAs, but there is always a technician, the ultrasonographer, who does the scanning, who holds a transducer when the FNA is done. But in the US, there are several institutions, especially some big private labs where the pathologists do the ultrasound-guided FNAs, but they always have a technician available to us. I think it's probably the standard approach, unless you are a certified radiologist yourself. You have a certification to do the ultrasound. Again, an excellent point that they could be good aspirators, your radiology colleagues, but they are poor at making good smears. They just need teaching. And I think just a day or two of teaching them, showing them how good smear is made would be adequate. So people often ask me why the adequacy criteria was not revised. I often talk about this, and we had every intention to revise it to make it lower, with the understanding that if we relax the adequacy criteria, we will have fewer repeat FNAs to perform, saving the patient the misery of waiting and coming back for a repeat FNA, also saving valuable healthcare dollars, and simply opening up the schedule for more patients rather than bringing the same patients back. And also the understanding that more than 95% of non-diagnostic FNAs on follow-up turned out to be benign. And also if we relax the adequacy criteria, we will not impact less than 3% false negative rate of a benign diagnosis. Despite all that understanding, we still lack good validation studies. So it's time that maybe someone could do such a study, which are harder studies to do, and show what should be the minimum number of follicular cells. So if you ask me what is my cutoff, if patient does not have a suspicious family history, clinical findings, imaging findings, I would call something adequate and benign with 3 groups of follicular cells. And if there is abundant normal appearing colloid, I would call something adequate even with 1 group of follicular cells. So it all depends on your comfort level. So we have left this open, but officially from a Bethesda point of view, giving a number, we still have kept the 6 group of follicular cells with roughly 10 cells each. So this presents an interesting problem. Very often thyroid nodules are cystic, either predominantly or they're complex with a big cystic component, as shown here. This is a big thyroid cyst with a very thin wall. It's totally anechoic. It appears dark because the ultrasound waves go through and through. And when you do the FNAs of these cysts, which are fairly common, you will just see thin fluid, which will not air dry on the slide, with the addition of numerous hemocyatin-laden macrophages, but no follicular cells. I know when we often call this non-diagnostic, our clinicians get upset and say, well, there's nothing for me to aspirate. There's no mural nodule. There is no solid part. And I did everything possible to give you a good sample. And that's the reason that we got rid of the word unsatisfactory. We call it non-diagnostic, but we highly recommend that you add a note that although non-diagnostic, if the patient does not, technically non-diagnostic, but if the patient does not have any risk factors like family history, clinical findings, or imaging findings like irregularly thickened wall, mural nodule, microcalcifications, so on and so forth, the clinician can consider it adequate and benign. But from your end, technically speaking, you would still put it in the non-diagnostic category. And we are not subcategorizing as the British, and I think now even Italians subcategorize their non-diagnostic cyst fluid only as a distinct subcategory. We don't want to create subcategories. We wanted to avoid that right from the beginning. We wanted to keep the Bethesda system very simple. So something like this will be called non-diagnostic by us, with a note that the clinician can consider it adequate if the risk factors are not there. And this illustrates nicely the reason for doing that, because papillary thyroid carcinoma is very often cystic. We call it cystic subtype of papillary thyroid carcinoma, which is not a WHO endorsed term. There is no histologic counterpart or a WHO recognized subtype of papillary carcinoma cystic, but we as pathologists and radiologists like to call it a distinct category from our point of view, because it helps us with our diagnosis and differential diagnosis, because we want to differentiate a cystic hyperplastic nodule from a cystic papillary thyroid carcinoma. So this is what typically happens. You will have a big cyst, and if you do it by palpation only, you can miss the mural nodule or the deeper solid part, and you will end up, for example, in such complex lesions, if you do it by palpation only, you will not get to this mural nodule with the these bright echogenic foci, which are the microcalcification, the most specific but not very sensitive feature of papillary thyroid carcinoma. So you want to sample these areas, the more solid areas. But if you don't do that, you will end up with a lot of cyst fluid, hemocyanin-laden macrophages, occasional cells which look like histiocytes because they have very vacuolated cytoplasm. But if you compare the nuclei, these nuclei look different. They are more oval. They have beautiful grooves, very fine powdery chromatin, and in some instances, beautiful intranuclear inclusions, with the understanding that histiocytes never have intranuclear inclusions. These findings are classic for cystic variant of papillary thyroid carcinoma. So watch out for these cells. Sometimes you will only have one small group of such cells in a predominantly cystic lesion. So either non-diagnostic if you don't have enough cells, or if you see clear evidence of papillary carcinoma, then you will call it a cystic papillary thyroid carcinoma. And these cells, which look like histiocytes, are simply undergoing this well-known phenomenon of hypervacuolization, that when you keep these epithelial cells suspended in fluid environment, like happens in CSF or CS effusions, these cells, which are epithelial, will imbibe or absorb fluid and begin to develop these soap bubble vacuoles, and hence they look like histiocytes. But once again, you can see beautiful grooves and intranuclear inclusions diagnostic of PTC. Sometimes they can really balloon up, and again, you may have a problem calling them epithelial cells, but clearly they are in fragments. Histiocytes are not in fragments, they are always single cells. And if you use liquid-based cytology, it gets a little bit even more complex, because everything looks histiocytic. So that's a histiocyte, but all these cells with gorgeous intranuclear inclusions are from papillary thyroid carcinoma. So benign, the most commonly used Bethesda category. It's a very satisfying diagnosis because we do a fairly good job with very low risk of malignancy. The high end is 6%. In our experience, it's not more than 3 or 4%. So the entities which are included in a benign are adenomatoid nodule, colloid nodule, which is simply an adenomatoid nodule with abundance of colloid. Hashimoto, the term we use in cytology, is simply lymphocytic thyroiditis, and in some cases of Graves' disease. Important to remember that these patients do not need to go for any type of surgery unless specifically indicated. And they are simply, and there's no need to even do a repeat FNA. You simply follow them up by clinical examination with possible addition of ultrasound if there's any clinical indication or risk factor. So this is what you would see. Hyperplastic nodule is a process of hyperplasia, so you will see abundant cells. Don't call it cellular adenomatoid nodule because, again, it has no significance. They are all cellular. So you have polymorphism in terms of architecture, small, large, intermediate sized follicles loaded with colloids, some free colloid in the background. Macrofollicles, you can disrupt them open, leading to flattening of the walls. Don't confuse this with papillary thyroid carcinoma because you have abundant colloid. Some cases have these beautiful artifacts called comet tail artifacts, septated, which simply reflects the high amount of colloid, protein rich. So ultrasound waves hit this protein and they create this comet tail artifact with long cytoplasmic tails, and this is what you would see, abundant colloid, so benign. Again, reminding you that you can relax the adequacy criteria for counting the amount of follicular epithelium in these cases. So very simple approach to the diagnosis. Very important for me at this point to mention that the new name that WHO endorses is thyroid follicular nodular disease. So this is what we recommend in 2023 Bethesda, that you will top line your diagnosis as thyroid follicular nodular disease. And we give you an option to put in parentheses or in a subnote adenomatoid nodule or hyperplastic nodule, whichever name you have been using, so that your clinician, especially in the beginning, would know that it's the same thing you were talking about, except that now there's a new WHO histologic term, which we in cytology have completely endorsed. So follicular nodular disease, that's what we would be using. So there are some issues, some complications in the diagnosis of hyperplastic nodule. It's not always that simple. And I'm only highlighting 3 of them. Sometimes you will have abundance of oncocytes. So it becomes an issue whether it's simply a hyperplastic nodule with extensive oncocytic or Hürthle cell hyperplasia, or you want to call it AUS or follicular neoplasm. Sometimes the needle may sample area of all microfollicles, and I already mentioned that it happens in 32% of the time. So whether call it adenomatoid nodule or go up to AUS or follicular neoplasm. And as I mentioned, the thyroid nodules are very often complex, so you will have cystic areas, and when you sample cystic areas, you will end up with these cyst lining cells, which have a histiocytic or a sometimes epithelioid look. Sometimes they can even have grooves or rare intranuclear inclusions, leading to an AUS diagnosis. So these are some of the scenarios where the interpretation of adenomatoid nodule might not be that simple. Also, to remind you, it's my favorite slide to show. I'm almost always show this slide to remind people that the most significant cause of making an error when you make a false positive diagnosis in thyrocytology is Hashimoto thyroiditis. I've occasionally, or actually quite commonly, sit with the endocrinologists when we have tumor board meetings or other discussions, and whenever I mention it to them that, oh, this was not a simple case because I saw that it was from Hashimoto thyroiditis and I saw a lot of atypia, it's hard for them to understand that, because for them Hashimoto thyroiditis is a very easy diagnosis because they have serological evidence or clinical symptomatology in the patient. But in cytology, when you begin to see the reactive changes in the follicular epithelium, the metaplastic oncocytic epithelium, it can look really quite worrisome for papillary thyroid carcinoma. So try to be very careful with these 2 cases, otherwise you will end up like this gentleman. So the evaluation starts with imaging. It's a symmetrical disease involving both lobes with widely dilated isthmus. You can see between these calipers, and you see the isthmus here. And in the beginning, in the initial phase, they are very vascular. So if you do color Doppler or you read the report, you will see abundant vascularity, which disappears in the more atrophic advanced stages of Hashimoto thyroiditis. So here is the problem. One or several of these nodules, which are simply lymphocytic aggregates, will become a predominant nodule, and that's when you will be asked to do the FNA with the understanding that patients who have long-standing Hashimoto thyroiditis have a higher incidence of thyroid neoplasia, the most common of which would be papillary thyroid carcinoma. So even with that knowledge that these patients have a higher incidence, you still should have a higher threshold before committing to suspicious of PTC or a PTC diagnosis. Otherwise, you will make an error. So this is a very important take-home message from me to you, that be very careful. So this is the typical scenario when we are lucky, which is most of the time you will see a biphasic or bimodal population of cells. You have oncocyte juxtaposed to these polymorphous lymphocytes, very often seen as a lymphohistiocytic aggregate. Sometimes they can be numerous single lymphocytes in the background. But look at these 3 images, which I've outlined with red lines, because I want you to concentrate on the appearance of these cells. Very crowded cells with a large nuclei, oval in shape, and at higher magnification, you not only see beautiful grooves, but you also begin to see intranuclear inclusions. This one has very fine powdery chromatin, oval nuclei, beautiful nuclear grooves, and intranuclear inclusions. But all 3 cases turn out to be benign Hashimoto thyroiditis. And here I am showing you some or all the nuclear features of papillary carcinoma and giving you the diagnosis that these nodules were benign, which simply tells us that we should be very careful in our interpretation and have a higher threshold for SPTC or PTC diagnosis when patient has Hashimoto thyroiditis. I'm not asking you not to make the diagnosis of PTC arising in Hashimoto thyroiditis. I make that diagnosis sometimes, but only in cases when I see multiple passes with edge-to-edge papillary thyroid carcinoma, short of which I may call them suspicious for PTC in a background of Hashimoto. Or if I see rare internuclear inclusions and nuclear crowding, I will simply call it AUS nuclear, which is the new term that we use now in Bethesda 2023. And I will mention in a background of Hashimoto thyroiditis. So again, disregard a focal atypia, or if you are concerned, call it AUS nuclear in Hashimoto, but reserve the diagnosis of SPTC or PTC when more extensive changes are present in multiple passes. AUS, as I mentioned, is now the new term which will not be using FLUS anymore, and these are the cases where the cytologic atypia is very focal or subtle, it's not benign. On the other hand, you don't want to have the patient undergo a lobectomy for follicular neoplasm or for SFM, so you use the term AUS. And again, the subjectivity is illustrated here that my AUS could be your benign, or your benign could be my AUS, or your AUS could be my PTC, and my PTC could be your AUS. So a lot of subjectivity, but what we have tried to do after much extended discussion, it was a personal push from my side as the co-editor of the book, is to make it simpler, because we have seen over and over problems with this interpretation. So I'm happy to report only 2 subcategories now would be used for AUS. And I'm not going to go into discussion of what AUS is, because it's very well illustrated in the previous editions as well. So this is how we have addressed AUS. Over the years, we have seen that AUS has 2 distinct subgroups when it comes to the risk of finding malignant tumor. Our own study that we published in 2013, we showed that AUS diagnosis with nuclear atypia carries a high risk of malignancy of about 48%, very high, compared to all other AUSs combined, which was 21 or 23%. So clearly, there are 2 distinct groups based on what happens to the patient when a surgery is done. And also now we have molecular analysis supporting the categorization into 2 groups. The high-risk group will have the BRAF V600D mutation, the most specific for PTC. And there are other subgroups. So this subgroup is when you see cytologic or nuclear atypia. When you see architectural or other forms of atypias, they tend to show more often KRAS, PTEN, PAX8, PPR gamma mutations, which are more common for NIFP or follicular neoplasm subtypes. So hence, we have every reason now that we should have 2 subgroups. Now they will be called AUS nuclear and AUS other, all other combined. So this is the more serious one, and this is the one which often would lead to molecular testing or even a lobectomy. And these others may lead to simple either repeat FNA or surveillance for the patient. Personally, I wanted to use high risk and low risk, but at the end we decided that this would simply alarm the patient or the clinician when the moment you use the word risk in the diagnosis, and hence we agreed that simply we will have AUS nuclear and AUS other. If you really want to have an internal audit for your cases in the department just to see what are the different subcategories of AUS as previously used, you can still call it AUS other, but in a note somewhere down in the report, you can say oncocytic or cyst lining cells or rare plasmacytoid cells or scanned microfollicular proliferation, whatever. But for your own information, not to confuse the clinician, the top line would simply say AUS other. So we use a test called a FIRMA, which is an NGS-based test now. ThyroSeq is another one which we occasionally used. A lot of other institutions are using ThyroSeq. They're all good tests. There's a microRNA test, Thygen Next, Thyramir, which is also available. So answer to your question, we use Afirma. All of them have a very good negative predictive value. So follicular neoplasm is the new term, which we will not be calling it suspicious for follicular neoplasm. I already explained the reasoning. Again, imaging can help. There's not much time to go over the details here, but just to remind you, this is a diagnosis which is based on architectural atypia, cell-to-cell comparison, nuclei, the whole cell will look very similar to a benign follicular cell, but they would be seen in that microfollicular trabecular pattern when more than 50% of your cellularity involving the follicular epithelium is microfollicular or trabecular with scant colloid, you will call them follicular neoplasm, as simple as that. But again, we are giving you an option to put a note that 1/3 of these cases may turn out to be hyperplastic nodules on follow-up, so that you will be protected. We still reiterate the slight modification we made in 2017 that you allow minor nuclear atypia included in follicular neoplasm, which means that if you have minor nuclear features such as nuclear enlargement, irregular nuclear membrane, or fineness of the chromatin features you sometimes see in papillary carcinoma, and it's a microfollicular or follicular pattern lesion, you would still call it follicular neoplasm. But I strongly recommend you do what I do in my cases. I write as optional note where it says that differential diagnosis involve NIFT-P. So it's very important for us to understand that NIFT-P is not a cytologic diagnosis, it's a histopathologic diagnosis. But we as cytopathologists should try our best in cases where we suspect something could be NIFT-P, potentially NIFT-P, we put it in the right Bethesda category, and the right Bethesda category is follicular neoplasm, because these patients will get a lobectomy, which is the treatment for a NIFT-P lesion. So again, follicular pattern lesion, you want to call it follicular neoplasm, but the moment you see some nuclear features, still call it a follicular neoplasm. But just clarify that differential diagnosis also involves NIFT-P, because in follow-up, if it's NIFT-P, everything is outstanding. NIFT-P, lobectomy, that's the end of the story. So it's very important that we understand that fact and try to include these potential cases of NIFT-P in that category. And of course, common knowledge, we cannot differentiate adenoma from a carcinoma, hence we always stop at the neoplasm diagnosis and don't go any further. Everyone knows how follicular neoplasm would look like, predominance of microfollicles with scant colloid, sometimes trabecular, sometimes these follicles would adhere together as seen here. What is a microfollicle? Microfollicle is a small structure, 15 or fewer nuclei in the form of a complete circle or a rosette. That's what defines microfollicular architecture. So if I would see this appearance as shown here, I would not even have a second thought, and I'll call it a follicular neoplasm. The other important thing, I will go back to this slide, is not the size of the follicle, which is important, but this so-called equisize or uniformity or monotony in architecture, because remember, follicular neoplasm, the thyroid recapitulates a copy the developmental or embryonal form of colloid, of thyroid, which is all microfollicular, and hence you see an overabundance of that pattern. If I begin to see colloid in the middle of these microfollicles, which you don't see here, those are the cases where I can suspect something could be a follicular variant of papillary thyroid carcinoma, because that's what happens. So in those cases, I will still call it follicular neoplasm, but just like in the case of NIFT-P, I may add that note, differential diagnosis also includes a follicular variant of papillary carcinoma. So this is where a big change has occurred in terms of nomenclature for, from the 5th edition of the WHO, that the word Hürthle cell is out. Now everything is called oncocytic. So using that recommendation, now we have a new name for these cases where you see oncocytes and you are calling it oncocytic or Hürthle cell neoplasm, that you will still include as a, because there's no separate category in the Bethesda for oncocytic neoplasm, because they are considered subtypes of follicular neoplasm. So you will call it follicular neoplasm, and then next line will say oncocytic follicular neoplasm as a subcategory. Two features which I favor when I favor a neoplasm over hyperplasia would be the proliferation of these fine capillary vessels and frequent binucleation. Every other cell has 2 nuclei with macronucleoli. These are the features that I would use to favor a neoplasia over a hyperplasia of oncocytes. A major differential diagnosis still involves parathyroid, incidental intrathyroidal parathyroid. And these are the cases where you see these very small cell size with numerous naked nuclei, vascular proliferation, a very neuroendocrine chromatin, and totally devoid of any colloid. Again, I don't have to remind you, when you're going after a thyroid nodule and you don't see any colloid, then the differential diagnosis should always include parathyroid, medullary carcinoma, and metastasis. Most common one would be parathyroid. We try to make cell blocks in every case because then we can do immunostaining. Shown here is a PTH immunostaining, which is cytoplasmic, but you can certainly do a GATA3, which is nuclear, and it works equally well. At Hopkins, several years ago, we published a series where we showed that if you are not certain that you will have a cell block later on because of the hypocellularity at the time of on-site evaluation, you can ask your radiologist, or if you are the aspirator, do an additional dedicated pass and rinse it in 1 cc of Hank's Barron salt solution in these small plastic bullet tubes, and send it for PTH analysis to a chemistry. And next day, when it comes back higher than the patient's peripheral blood PTH, it becomes diagnostic of parathyroid lesion. So that's the word we use, parathyroid lesion. We don't call it hyperplasia, adenoma, or carcinoma. These days, we have another very useful antibody available to us, which is called parafibromin, which is derived from this tumor suppressor gene, HRPT2 hyperparathyroidism 2. And it has a very impressive profile. It's lost in parathyroid carcinoma, and it's retained in parathyroid adenoma with a sensitivity of 96 and specificity of 99%. So in cases, for example, in this particular case, we were asked the question, could this be a carcinoma? It was a neck nodule, not in the thyroid. And when we did parafibromin, it was strongly positive, and we signed it out as ectopic parathyroid. And we were right when it was excised. So again, the antibodies to diagnose something as parathyroid, and then you could certainly take a step further and do parafibromin to differentiate adenoma from carcinoma in selected cases. So this is a very important, frustrating areas, the indeterminate thyroid FNAs. As we know, a certain percentage are either AUS or follicular neoplasm. Majority, unfortunately, are resected, and majority, unfortunately, turn out to be benign. And hence, it adds to a lot of grief and frustration, both for cytopathologists and the treating physician. And hence the use of commercially available molecular tests, which has really proliferated. They are very commonly used in thyroid cytopathology in the US. There are several tests available. This is the one that we do, Afirma. ThyroSeq is equally good. ThygenNext or Thyramine is also a very useful test. As you can see, they are successful because of the very high negative predictive value, 96, 96, and 94%, meaning that if test is negative, patient will have very low risk of having a malignant tumor. And in follicular neoplasm or AUS diagnosis, when the test is negative, no one will operate on these patients, obviating the need of an unnecessary, expensive surgery. Lobectomy is a very elaborate procedure. So it's very important for us to realize that these are here to stay. They are very important because they significantly increase the preoperative diagnostic accuracy of an FNA diagnosis. And we all know that FNA sample, the liquid sample, is an excellent sample to do these molecular tests. And by combining the FNA tests and the molecular tests, we increase the accuracy. Downside is that they are very expensive. So those of you who think that we will not have thyroid cytology, we will be looking for a new job. We have lost a lot of Pap tests to HPV. You're wrong, because these tests are so expensive, they will not be indiscriminately offered to every patient with a thyroid nodule. You will only offer them to cases where it's either AUS or follicular neoplasm or suspicious of malignancy in selected cases. The manufacturers claim that ThyroSeq and ThygenNext have an advantage, that they both could be done on scrapings from already prepared pap-stained smears. But these impressive NPVs and PPVs only are published on the liquid sample. So the diagnostic accuracy of these tests will go down if you don't do them on liquid sample, but do them from scraping of the slides. And ThyroSeq additionally claims that you can actually do it on paraffin cell block as well. I don't have much experience with these two tests done on cell block or cellular scrapings, but I do have the understanding that liquid sample is still the best and the most accurate test when you employ that particular sample. SFM, no significant change, but the risk of malignancy is high, so a lot of time the patient will be taken for lobectomy or total thyroidectomy. Important thing is to still, again, remember my basic pointer to you, which I gave earlier, that if you suspect something could be NIFT-P, like you see here, follicular pattern lesion, with some nuclear features such as enlarged nuclei, some grooves, rare intranuclear inclusion, some pleomorphism, do not go to SPTC diagnosis. Call these cases follicular neoplasm with a note that differential diagnosis includes a NIFT-P, so that the patient will get a lobectomy. Unfortunately, these 4 cases were diagnosed as suspicious of papillary carcinoma, leading to overtreatment, total thyroidectomy rather than a lobectomy. So finally, malignant, very specific diagnosis, near 100% positive predictive value. These are all the different type of cancers we diagnose. Important thing which often people ask me is, do we diagnose the subtypes of papillary carcinoma? Also important to note is that the new WHO classification now is using the word subtypes. The variant is out, so that we don't create confusion with the molecular genetic variants of papillary thyroid carcinoma, and the clinicians don't get confused. So we use the term subtypes. So I usually tell people, don't get into subtyping the papillary thyroid carcinoma, because it's not always accurate. Sometimes if you're calling something tall cell variant, it could be a very focal change, and using the histologic criteria of 30+% of tall cell feature, you may not see that in the resected specimen. But usually, since these are aggressive variant, may lead to the neck dissection, I usually say it as a note if I see the feature. So papillary thyroid carcinoma, note focal features suggest tall cell subtype. Sometimes that's helpful. So these are some of the examples. As I mentioned, these punctate echogenic foci, which translate into microcalcifications. The groups of Samoma bodies are highly specific, although least sensitive for papillary carcinoma. So imaging definitely helps. I don't have to mention any features to you here. Beautiful fibrovascular cores, Samoma bodies. These are the major diagnostic feature, but seen in minority of cases. How often? 15%, at the most 20% of cases. Most often we rely on nuclear features, high magnification, oval nuclei, fine powdery chromatin, longitudinally running grooves, tiny marginal nucleoli sitting underneath the basement membrane, or these gorgeous intranuclear inclusions, which are quite specific but not 100% specific. I already showed you example of Hashimoto thyroiditis. You can see them very commonly in medullary thyroid carcinomas as well. So, but when you see them in the right context, they become diagnostic of papillary thyroid carcinoma. Do we really have to have intranuclear inclusion before we call something papillary thyroid carcinoma? And the answer is a big no. We diagnose PTC even without intranuclear inclusions all the time. So these are some interesting subtypes. I'm only showing you 2 because these are the most aggressive subtypes that can be seen on cytology, although you need some experience. So these 3 are the tall cell. The cells are tallish, as you can see here, but don't look for those nice columnar shapes, because in cytology you tend to have these cytoplasmic tails more often. They look more oncocytic, especially in cell blocks. As you can see here, very eosinophilic cytoplasm. They are loaded with intranuclear inclusions, sometimes multiple intranuclear inclusions called soap bubble intranuclear inclusion. So I may mention that in my diagnosis, with the understanding that patient may get a prophylactic level 6 paratracheal central lymph node dissection, which good surgeons only will do if they can palpate the enlarged nodes, or if imaging shows the enlarged nodes, or if you say tall cell variant, or if it's BRAF positive molecular analysis, because it's associated with the 2 potential complications of thyroid surgery, permanent hypoparathyroidism and recurrent laryngeal nerve damage. These 2 slides which I'm showing you, if I show them to you as a liver FNA in a patient with history of colonic adenocarcinoma, you will call it colonic metastasis. But if it's in the thyroid, that's how the columnar cell variant would look like. Beautiful columnar cells which are tightly picket fenced against each other. So again, a very aggressive subtype. The hobnail is another aggressive subtype, and I've occasionally seen that it will have very well-developed cytologic features, but again, optional. If you don't feel comfortable, don't be compelled to give a subtype diagnosis. Another change which has happened is that we have taken out the cribriform morular thyroid carcinoma as a subtype of papillary thyroid carcinoma in the new WHO classification, because we now have the understanding that it's of uncertain histogenesis. It has a totally different molecular pathway, the Wnt beta-catenin signaling pathway, unlike papillary thyroid carcinoma. So that's the new WHO name, cribriform morular thyroid carcinoma. We also know very strong demographics for this case, practically seen in young females 97% of the time. So this is a very helpful thing for us to consider when we are diagnosing something as cribriform morular thyroid carcinoma. And why is it important that we identify it as such? That is listed here. More than half of them are associated with the familial adenomatous polyposis or Gardner syndrome, meaning these patients have a higher risk of developing colonic adenocarcinoma at a much earlier age. And sometimes your diagnosis of cribriform morular would be the first diagnosis this patient will get, and then the patient will be put on surveillance for colonic polyps, or in extreme cases can even get a prophylactic colectomy. So it's very important that we remember that fact. And also, when you diagnose this tumor, you should also convey to the clinician that this will behave almost like a benign tumor or very indolent tumor with very low mortality. So that's also important information that we should remember. So this is the morphology. You see beautiful cribriform spaces, and you can see the resemblance to papillary thyroid carcinoma, flat monolayering, or these papillary-like fragments. There's another avascular core surrounded by these very tightly placed epithelium, raising the possibility of papillary thyroid carcinoma. That's higher magnification. Some cytoplasmic tails or columnarish look is classic for cribriform morular. But the most important feature, which I highlighted here in red line, is the occasional presence of these so-called squamoid morules or squamous morules. And this is the most important specific finding, because this is the area which stains in a nuclear configuration with beta-catenin. Beta-catenin is a cytoplasmic or a membranous stain. But when you have these squamous morules and you see this beautiful beta-catenin stain, and it becomes virtually diagnostic of cribriform morular thyroid carcinoma. Just to remind you that in some cases they could be positive for TTF1, but they are usually negative for thyroglobulin and PAX8, which are the two most common markers we use for thyroid follicular neoplasms. Medullary thyroid carcinoma, most of the time easy diagnosis, but it has the widest spectrum of cytomorphologic changes. Hypercellularity is the key. They will be very cellular because they are stroma-poor tumors. They can be plasmacytoid. They can be a combination of plasmacytoid or spindle. They are almost always, in at least 65-70% of the time, have an appreciable amount of colloid. They are loaded with intranuclear inclusions, so never jump to PTC diagnosis with intranuclear inclusions, because you can have an MTC with beautiful punched out inclusions. On liquid-based cytology, interestingly, they can look very histiocytic. But these cytoplasmic tails help, because histiocytes would not show these tails. It's something which is typical of medullary thyroid carcinoma. This is a table from our new edition of the book. As you can see here, they are also notorious for having so many growth patterns and cytologic features, raising a long list of differential diagnoses. I don't have time to go over each and every one of them, but I just wanted to show you a spindle cell, where you can think of a spindle cell neoplasm, primary or metastatic. They can be very pleomorphic with giant cells, raising the possibility of anaplastic carcinoma. Or they can be very small cellish, raising the possibility of a metastatic small cell carcinoma. So these are the three important ones that I've occasionally seen, but there is certainly a list of other subtypes as well. The other thing which we recommended in 2017 with HISDA, and we maintained in 2017, is that if you think you will not have a cell block to confirm the diagnosis later on, you can consider sending the needle washout for calcitonin level, just like you did or you often do with PTH diagnosis. And if it comes out back higher than patient peripheral blood calcitonin, it also is a supportive evidence that you have a medullary thyroid carcinoma. So not only in nodal metastasis, but you can even do it on the primary thyroid lesion. Ki-67 grading, which is now recommended by WHO to subcategorize them into high or low grade tumors, is not recommended in cytology. I'm strongly against doing Ki-67 in a cytologic sample. So this is a very interesting name for this tumor in the new WHO. When we were writing the book, we had a hard time abbreviating the tumor. It's called high-grade follicular cell-derived non-anaplastic thyroid carcinoma. So these are the tumors which sit between the differentiated thyroid tumors, papillary and follicular, and anaplastic, because they have intermediate prognosis. The older subversion, or the older original subtype, insular, we know now it's called poorly differentiated thyroid carcinoma, but we also have the differentiated high-grade thyroid carcinomas, which are either PTC or follicular carcinomas, which show high mitotic activity and focal tumor necrosis, something which is not often seen in cytology. So I still believe that this would be a very hard tumor to diagnose on cytology, and most of the time will simply be called PTC or follicular neoplasm, but the insular ones we know can be diagnosed adequately if you have the right features for insular carcinoma. Finally, anaplastic, as the name suggests, extensive pleomorphism or anaplasia. You can see and compare the nuclear size variation. It's extensive, so easy diagnosis. But important thing is to exclude metastasis. That's a metastatic melanoma, which looks very similar to anaplastic. So every time you are diagnosing something as anaplastic and differentiated, look at the history very carefully, or do immunostaining. Despite the fact that they lose thyroglobulin, TTF1, and even cytokeratin immunostaining, they still retain PAX8 in a high percentage of cases, so that's helpful. They're aggressive tumors, so looking at imaging finding or clinical findings is always helpful. The history is typically in days or weeks. It's not even in months. Important change with the new WHO is that this thing, which clearly looks like a squamous cell carcinoma keratinizing, is now considered a subtype of anaplastic. It's not a separate tumor. So if I would see something like this in a thyroid FNA, I would call it squamous cell carcinoma, either primary or metastatic or locally invasive from, say, a laryngeal primary. After I exclude that, and I would confidently then say anaplastic thyroid carcinoma, squamous cell subtype. That's how these cases should be signed out. So NIFP, again, quickly repeating myself, is not a cytologic diagnosis, and we don't have any criteria to diagnose it on cytology. Some things quickly about where the future is for thyroid FNA. We are seeing increasing role of molecular tests, and we have started to see the impact of machine learning or artificial intelligence or computer-aided diagnosis. Still very early, and I don't think that it has an established role. But molecular tests certainly are more often done, not only for cancer diagnostic, but provide useful prognostic information and also provide an avenue for targeted therapies in precision medicine. We know that there are multiple kinase inhibitor drugs which are routinely used in major medical centers to treat thyroid cancers. Not only those, but we have targeted therapies available. Say, for example, if it's an NTRK mutated thyroid carcinoma, you have NTRK inhibitors available. Likewise, RET inhibitors for RET fusion thyroid carcinomas. So it's important that to recognize that we have the ability to treat more aggressively in thyroid cancers, but only can happen if we have these molecular tests available at our institution. So giving you just one quick example, TERK and ALK mutations often included in these commercially available molecular tests confer a high aggressiveness to these tumors with high mortality and all the bad characteristics that these patients can have. NTRK rearrangement, it's a hot topic. Often people go into in-depth discussion on this because these papillary carcinoma, which are NTRK rearranged, are quite aggressive with multifocal or multinodular growth pattern, and more often nodal metastasis very early in the disease. And there are papers which show that FNA may not show very well developed nuclear features of papillary carcinoma. So sometimes these molecular tests can really aid in the diagnosis of these NTRK rearranged papillary carcinoma. An important thing is now we have specific therapies available for these cases. NTRK fusion thyroid carcinomas are often treated with larotrectinib, and the one which are highlighted in yellow, and the list is expanding, are the FDA approved agents. But we have certain other things available to us, like dafrabenib is quite commonly used in cases which are radioactive iodine refractory, so it redifferentiates these tumors, and then when patients get radioactive iodine, they respond better to that treatment. So again, there's not enough time, but just two more agents I wanted to mention, especially the pralsetinib, which is now very often used in RET-mutated medullary thyroid carcinoma with more aggressive locally invasive disease. So with that, I end my presentation. I know it was a lot to present to you, but I just wanted to present a hybrid model of Bethesda system, as well as just to have a refresher course on the salient cytomorphology of important thyroid lesions. So with that, I end my first lecture. Then subsequently, I will do the unknown cases. But at this point, I'll be happy to take any questions you may have.